So that really, then that's a couple of things. Number one, it's understanding health plans.
Yeah.
What is the purpose of health plans, where they came from, and what their financial priorities are, right? What medical loss ratio means,
Right.
What are their incentives to decrease cost?
Right.
What star ratings mean? What are their incentives to improve revenue? What their priorities for recruiting and getting more members, right? They're for-profit entities. And there are quite honestly very few clinicians who are A, curious about that, or B, who actually have the knowledge to do that. I think, 15, 20 years ago, a lot of these folks were seen as sellouts. Oh, you're going to go work for a health plan? You're a sellout, right? You're kind of betraying the cause. You're going to the dark side, very Star Wars-esque mythology. I think the reality now is that, look, the system is a lot different than it was even 30 years ago. You don't have this artificial barrier between payer and provider.
Right.
Some of the largest health plans in the nation have either owned, purchased practices outright, or have affiliated with them in a very loose funnel. And, we've of course had an evolution of value-based care where, we have accountable care organizations like ACOs. We have various capitated models that have been released from CMS, right? Like the CKCC model in nephrology, or, most recently the GUIDE model in dementia, which really ties payers and providers very closely as they're now taking some risk, right? And we're really kind of changing the system away from, pay for volume, right? Which is, hey, you see a bunch of patients make a lot of money, really towards like pay for quality or pay for cost. So the system is just a lot different than where it's been, which means the type of people that companies want to hire has also changed and the priorities have changed.